Thank you so much, Jodim. That was amazing. How do you follow that? What an inspiring presentation. And thanks as well to Jesse, who had an amazing overview of Alberta's quality indicators and framework. I wanted to start out by, I guess, looking around this room, and I feel very privileged to be amongst a group of what I can only describe as some very esteemed health leaders. Dedicated to making a difference in Alberta. I work with many of you, and I'm deeply inspired by the work that's happening right now across this great province. And it's not just the cliche. I don't say it lightly. I don't think we stop often enough to thank our public sector health leaders. Recognition tends to be few and far between. I've been in your shoes, and my teams and I have lived it, whether it be during media spotlights or Senate inquiries, what seems to be crisis after crisis, especially as we look back on the last 5 years with COVID and the pandemic. And I wanted to first capitalize on this opportunity and the audience in front of me and really just say thank you for what you do each and every day. As leaders, our job is to nudge and influence and guide, and yes, sometimes drag the system along. And not necessarily where it wants to go, but where it needs to go. And it's not easy. So if it was easy, it would have already been done. So thank you for everyone for coming today, and thank you for being part of the transformation. Some of you may not have heard of Nous, but Nous in French obviously said Nous. Of course, means we, us, together, community. In English, it means pragmatic, intelligent, and know-how. And in classic Greek, it means instinct, insight, and soul. So Nous Group operates across Canada, New Zealand, UK, and Canada for over 25 years. And we try to achieve what we call a bigger idea of success. So my goal today with you is to achieve a bigger idea of success with our great partners at the Institute of Health Economics, Jodim at IFIC, and Jesse at Health Quality Council Alberta. And I'm hoping I'm able to achieve that with you today. Thank you, John, for the amazing introduction. Just a bit about myself. So I've spent the last 25 years in the health sector across Australia and Canada. As John mentioned, I spent half of that in the system as a New South Wales Ministry of Health ADM equivalent and executive director, leading change across a large system, which I'll talk about in a moment, and as a CEO of a primary health network. And primary health networks in Australia are similar in size and scope to primary care Alberta, although my population was based in Western Sydney, a population of about 1.5 million people. I spent the other half of my career consulting across every Canadian province and every state and territory in Australia, as well as with the Commonwealth Government in Australia and federally here in Canada. So over this journey, I've had the privilege to learn from some great mentors, work with some great organizations, and really meet a lot of great people. And so over the next 15 minutes or so, I hope to bring you a few practical implementation examples from Australia on what's been achieved toward delivering this high-performing integrated system. And some of these success factors that are really important to driving that change across the system, both within the communities that Jodim mentioned, but also system-wide, as we all operate in the political frame within an election cycle. And so some of the models of care and those clinical pathways, those integrated pathways on the ground that Jodim mentioned, I'm going to give you some practical examples of how we were able to progress those things locally, trying to build towards that population health. So there are three things that stand out to me as critical in designing and delivering a high-performing integrated system. So a performance framework, measuring and focusing on what matters, and setting clear performance expectations. Performance reporting, collecting data and using it multiple times so that there's a single version of the truth where it's accessible and reportable and supporting continuous improvement across every player within the system. Everyone's looking at the same data, like Jodim mentioned, the same dashboard, the same information. It's transparent for everybody. And the third thing I'll call is a flagship change program, which is collaborative commissioning in my example, but it's aimed at supporting the change and funding improvements and which can bring people together toward a common aim. So there's something tangible to link people to get people excited to drive that change forward. Australian and Canadian health systems are more similar than many may think, and so I'll take you through some specific examples from Australia in each of these areas. So for those of you who have never been to Australia, it's about a 15 or 16-hour flight. You can get it direct from Vancouver. I highly recommend it. It sits on the east coast of Australia, beaches, deserts, mountain ranges, rural areas, metro areas, you name it, it's got it. And I highly recommend you visit during the Albertan winter because it's very hot and sunny. But if not for the weather, and for the amazing people, for the fact that Alberta and New South Wales are really oceans apart, but they're two sides of the same coin. So both are organized into primary care regions. So in New South Wales, there's 10 primary health networks, and I know Alberta is moving to 7 corridors of care. Both have similar numbers of hospitals, including large tertiary facilities, small multi-purpose services. New South Wales is organized into local health districts, similar to how the zones used to be organized in Alberta, although obviously very different in terms of context and operating environment, governance, and that sort of thing. There's more people in New South Wales, of course, around 8 million compared to the 5 million in Alberta, approximately. But both have big systems with similar volumes. So similar numbers of family physician visits, numbers of full-time physicians, ER visits, and budgets per capita. Both, in fact, have similar private delivery of healthcare, and I know that can sometimes be a dirty word in Canada. But it's around 30% of healthcare is delivered in the private not-for-profit, by private not-for-profit organizations. So the main difference, of course, everyone raises with me when I say that is, well, the legislative framework is different. We have the Canada Health Act. You can't pay for medical care in Canada. But we all know that healthcare is, of course, much more than medical care. And the percent of private expenditure in Canada and Australia is similar at around that 30% mark. So Canadians might not be paying as much for medical care, but we're paying about the same for our total healthcare journey. So with these similarities in mind, let's delve into each of those 3 domains that I mentioned earlier. So the New South Wales Performance Framework sets the performance expectations for the system. It communicates priorities and clarifies roles and responsibilities of each organization across the system. It sets the processes and procedures by which performance is managed, everything from targets to performance escalations, processes and procedures of how that escalation happens. And it details the cadence and nature of performance meetings. It's very specific. Everyone knows what to expect. Those meetings happen between the ministry and the system, and it gives us a frame in which to work on that common set of data towards an improvement at the micro level, at the meso level, and at the macro level. But although the New South Wales Performance Framework it gives you that blueprint by which performance expectations are set and lays out how it's managed, supported, and improved, it's only a playbook. It needs a team coach, and assistant coaches, and a team of leaders to run the plays. So in New South Wales, they have a term which they refer to as the system manager, and they call the system manager the brains, consciousness, eyes and ears of the health system. In New South Wales, the responsibility sits with an ADM of system purchasing and performance. That's the coach. The division under the ADM has 4 key functions, each led by an executive director, the assistant coaches. Purchasing carried out health system planning and commissioning, contracting, financial stewardship, system information and analytics, monitors system performance, supports improvement through data-driven decision-making, provides transparency and access, data and public reporting, and enables integration and coordination across the system. So it's the insight, it's the information under which the system manager operates. Quality improvement facilitates skill development and shared learning, supports change management, facilitates consistency and collaboration, and then improves culture, helps improve culture, job satisfaction, and engagement. Super important in integrated care initiatives. And finally, performance management, the black hat. So if quality improvement is the white hat, we're here to help. Performance management is the black hat, compliance, escalation. And all of these functions I've found over many years to be very important. They reinforce each other. There's a role for each of these in a high-performing, integrated, safe system. By way of example, New South Wales local health districts were formally assessed and reviewed quarterly, and a performance rating was made and available to the public. So we didn't start with public reporting. That's quite scary. But over a few years, that became public knowledge in terms of what rating, 0, 1, 2, 3, 4, each local health district was going to receive. So from no performance issues right through to challenged and failing. And I can tell you from experience, not many hit 4, because as they improved and understood what was important, they moved up to 1 or 2 and then moved back down to 0. So it was a reinforcing improvement mechanism. But it was a way to call out amongst a whole range of different stakeholders, boards, executives, on the ground, frontline services, clinicians, that there was some problems that needed to be solved together. So the review, release, and rectification process applies pressure across the system to galvanize action and innovation and collaboration within services and with external partners to continuously improve performance. Integration is not just an idea, it's everyone's day job. Everyone comes to work every day and knows this is what's important. So the passion and ambition of those on the front line is visible, it's shared, it's connected, it's publicly available, everyone knows where they're going. Because when you're communicating within a system, it's very difficult to get the word out, especially to external partners, which are part of the solution. And you really need those partners at the table to help you solve the problems that you're addressing, because these are complex, multifaceted issues. So the performance framework over the years progressively added more integration measures. Performance meetings also evolved to invite other partners. So it wasn't just the ministry meeting with a hospital or a local health district. It was an invitation to a primary health network, invitation to community providers, invitation to education, social services, other human services, to participate in deep dives into various aspects of performance so issues could be worked on collectively and together. Government set the expectation with health boards and CEOs, and government took their own action to enable the rectification of issues that sat with their division or branch, which was absolutely essential because a lot of this sits in the policy frame, in the legislative framework, and not actually with frontline services. So it wasn't like the service was going back to the frontline and saying, it's all our job. It was the ministry actioning things as well. It was other government departments. Sometimes it's education, sometimes it's social services, sometimes it's the policy frame. So in a large part, the clarity that was provided by that performance framework allowed the system to work together to address the issues that were most important for that day, but also, not just that day, for the longer term. So everyone knows where they're going, but what's important today and this year. So the performance framework was implemented progressively from 2012 onward, and the performance imperative for the meaningful use of high-quality data was set. So you cannot implement a performance framework without high-quality information. So similarly, around the same time, New South Wales was also moving to activity-based funding, patient-focused funding, as it's also referred. And so the imperative for data also became important because it wasn't just about the performance measures, it was about funding. So now your funding is also tied to the quality of the data that you're collecting. So we had to focus on data, and so I'm going to dig into now the second example, which is performance reporting, transparency, and accessibility. So a passion of mine is data governance. And I know it sounds very boring, and people's eyes glaze over when you say, oh, data governance. Someone says, I love data governance. But strengthening data governance, not just within the acute sector, but across the continuum of care, is absolutely fundamental to both integration, safe and effective, high-quality care, et cetera, et cetera. And we all know that health data is super important. It sounds like a cliche. It's collected as a byproduct of clinical care, but it's also collected patient experience, patient-reported outcomes, workforce data. We seldom achieve a pragmatic agreement on what data sets are important for us to manage the system and how they're being used. So in New South Wales, agreeing to a data governance framework it seemed like when we started, everyone had their own data set. So it's like a data set, it was a database, it was a register. There was no consolidated list of what data was important and why that was important. So we needed to be clear on what each statewide data asset was. And yes, I use the term a statewide data asset. We weren't going to try to solve every problem because every hospital had another version of the truth. We were going to say these are agreed across the system as the statewide data assets. We're going to agree on how they're used and who is responsible for sponsorship, custodianship, and stewardship of that data. And this all covered conceptually in the data governance framework, but practically in guidelines and policies. So very specifically, like these are 100-page documents that go into lots of detail about each one of the individual statewide data assets. And along with data governance clarity came the opportunity for the system manager to deliver on their mandate. So data became the lifeblood of the system, but more than just the system, we agreed on how to use that data. So at the regional level, we had real-time collection and reporting, improving data quality, monitoring workflows, rostering, models of care, continuous improvement, improving culture. So that's at the regional level, at the local level. At the state level, internally first, we had reporting monthly. So every month, my team within System Information Analytics would report monthly across all of the measures. So we benchmarked across the 277 hospitals, 15 regions, supporting statewide improvements and enabling the system manager function. We also had public reporting at the state level, reporting quarterly to citizens on performance, doing deep dives into specific areas of interest and reinforcing public accountability. So that pressure that I mentioned earlier about that self-correcting across thousands, tens of thousands of people. So the system had 200,000 employees. That's in the public system. And then we had hundreds of thousands operating outside the public system with hundreds, if not thousands, of organizations. How are they going to get a look at how the system's going? Well, it's publicly reported, much more granular than CIHI does now. So we have the IHW, which is the CIHI equivalent, which reported annually on activity spending and on national areas of interest leading to national standards development and benchmarking as well. So that's national benchmarking. So my experience is each of these are super important over time. It all doesn't happen at the same time. This, again, from 2012 was progressive over about a decade of internal capability and capacity development, and then external, and then national. At every single level of the system, we focused on building partnerships. So local partnerships, state partnerships, external, internal. Partnerships were the absolute foundation, as everyone knows, to integrated care. And data and analytical capabilities, you might say, you can standardize and you can have a shared service around that. But we found that it's absolutely important to have that capability sitting within each of those respective parts. Local capability around data analytics, state, et cetera. So in New South Wales, just to dive in a bit into the detail, we had 10 domains, and Alberta obviously has different domains, but these are going to ring very true and clear. Every context is slightly different, I know, but just to give you a deep dive example, we had safety, patient-centered culture, efficiency, equity, timeliness, and accessibility, effectiveness, appropriateness, population health, finance, and volume activity. And we defined KPIs and improvement measures. So KPIs were for the purpose of improvement, for performance. So they had targets, and they either delivered or didn't deliver. And improvement measures were for the purpose of ongoing improvement. The negotiations with every single branch across the ministry and divisions went on and on and on to agree these 31 KPIs. So we started with hundreds. And I got in some pretty heated discussions to get it down to 31, because you can't do everything all the time. And so these were the 31. We can answer questions on it later. I can see John standing in the back of the room, telling me I've got a few minutes. But you can see elective surgery access performance, so category 1, 2, and 3. So was surgery done within a clinically recommended time frame? You can see ED performance, ER performance, the percentage of people through the emergency department within 4 hours. And then we've got improvement measures, and yes, there are hundreds of improvement measures. because improvement measures are not for the purpose of performance, so we were more lenient on what was able to go into that bucket. Potentially preventable hospitalizations, unplanned hospital readmissions, you'll recognize many of these. We even got down into the electronic discharge summary was created within 48 hours, and the percent of discharge summaries that made it to the primary care provider. So that connectivity, so not for the purpose of performance, but we need to make sure that happens because we know the transfer of care is super important to outcomes. And finally, we had a linked data set. So as we matured as a system, we were able to move to a linked data set across primary and acute care. And I wanted to leave this slide here, just as I do my last example, John. I'm going to be 5 more minutes, I'm sorry. But Lumos was a passion of ours, and it still exists today, and it's going gangbusters. It's linking data. It's able to look at an integrated care pathway across the whole pathway, every provider, extracting data from primary care, linking it to acute care, and able to evidence the investment made in prevention is delivering what it was meant to deliver. So my final example, collaborative commissioning. So collaborative commissioning is a partnership between local health districts, primary health networks, PHNs, and other service providers. So it brings together primary care, community, and acute care in a shared responsibility for delivering a particular outcome. And what I wanted to flag with this is it's not the center, the ministry that's defining what those outcomes are. It's the ministry asking the community of providers, the front line, what would make a difference to the KPIs and improvement measures I mentioned. So we have a clear definition of what good looks like. You tell us what would make a difference for your local community, but would also help deliver against these outcomes that we're after, because we've all agreed that these are the outcomes we're after. So through a joint development phase, including consumers, physicians, nurses, allied health, a group of this many people and more, over a year, we designed an integrated care pathway. So the first example, I've only got 2, John. The first example I brought along was a pathway to prevent strokes and heart attacks, early identification of atrial fibrillation. So the diagram shows a risk stratification done in community health centers and done in primary care practices to identify at-risk patients, which are then monitored using a remote ECG and identified to cardiology clinics where symptomatic AF is detected. Joint management plans are done through multidisciplinary case conferencing, and then ongoing management is led by the family doctor and the patient, with escalation pathways to the specialist clinic. And appointments, by the way, can be booked the next day, fully integrated. And every partner coming with their own resourcing to say, I 100% am behind you in delivering this pathway, and the ministry is just funding 5 or 10% that's missing in the spaces between. The second example I wanted to give you is another passion of mine, which is the value-based urgent care pathway. And the diagram shows a central intake line used to triage patients' calls to complement referrals from partners in the neighborhood. So during that joint development phase, the neighborhood was empowered to then refer to this new clinic. But more than just the clinic, that clinic was delivered in primary care with the help of supplementary grants, but that was connected through infrastructure to their usual care family practice. So there's a discharge summary created, which could then be sent back to their usual primary care practice. There's a specialist outpatient line that practice could ring so that would avoided that ER visit. And there was infrastructure, digital enablement across that whole system. So it wasn't just a clinic, it was linked into the broader ecosystem. So again, these sorts of pathways can only be designed on the ground. And because we had Lumos, we could show sustainability. So the value-based urgent care pathway within 3 years broke even, and the atrial fibrillation pathway within 5 years. Government loves to see cost-benefit analysis, so it's very helpful to have the data. The dynamic simulation modeling that we did, we tracked every year the data went in, and we said, how are we going against this line? And why are we falling behind, or why are we ahead? What happened? And we had evidence that we could share with all of our partners about prompt follow-up. So we had 32% fewer readmissions within 2 to 6 days if we had that follow-up from primary care. So the connection, the space between the acute presentation and the primary care practice that follow-up needed to happen. That discharge summary needed to make it because we needed to impact unplanned readmissions. So it all connected to each other, and then we started to see unplanned readmissions move because we were doing it together. As you can see, I get very excited about these things. So final slide, there's no silver bullet, as we all know, to delivering integrated care. But there are a consistent set of enablers that require, that can help us achieve that integration, both at the operational and governance level. So we talked about the performance framework, we talked about performance reporting, we talked about change program, collaborative commissioning. I've obviously simplified this down, and there are many other things that are important to driving implementation, but I hope the experience and approach from New South Wales has been a helpful way to step back and reflect on the path forward. And I'm really excited to answer any questions now and engage in a discussion, so thank you.